Buenos dias, señoras y señoras. I'd like to thank the organizing committee for inviting me to speak here. Unfortunately, due to the COVID-19 situation, I can't meet you in person, but you will have to make do with a digital representation of myself. I will give you an update of the medical treatment of diabetic foot infections. My name is Edgar Peters, and I'm an internist from Amsterdam. I don't have any financial disclosures. Other than that, I have been a member of the International Working Group Diabetic Foot and of the Infectious Disease Society of America and the Dutch Multidisciplinary Committee that developed guidelines for diabetic foot diagnosis and treatment, especially about diabetic foot infection treatment and diagnosis. I've received some non-pharma funding, and I work at Amsterdam UMC location VUMC. And as you can see here, people are lining up to be seen at our diabetic foot clinic. My take-home message and goals of this presentation are that you then know that infection is a clinical diagnosis. If you want to prescribe empiric antibiotic treatment for diabetic foot infections, you have to know your local resistance profile. In case of mild infection, cover Staph aureus and streptococci. In the case of moderate to severe infection, also include gram-negative organisms. Most of the things that I will be saying are from the International Working Group guidelines on the diagnosis and treatment of foot infection in persons with diabetes. Guidelines were published in 2020. And the group was chaired by Benjamin Lipsky. The secretaries were Eric Salville and myself. And as you can see here on the left side of the slide, that the members of the group were from various parts of the world. You can see a picture of us in London Heathrow Airport where we're working on the guidelines. Some of the members have an infectious disease background, some of them medical microbiologists, endocrinologists, surgeons, vascular surgeons, podiatrists. It wouldn't surprise you, though, that at the same hotel, at the same time, at the same floor, there was another literature review going on of another society that were working religiously on their guidelines as well. What we did with the working group is that we reviewed over 15,000 titles, identified 53 studies with a contemporaneous control group to a therapy of diabetic foot infection. 25 of those were to systemic antibiotics. 11 of those included subjects with osteomyelitis. One study was to bone biopsy culture-directed therapy versus swab culture-directed treatment. 5 studies were to surgical intervention. And in general, we didn't find any differences among antibiotic regimes, except that patients on ticacycline did not do as well as ertapenem and had more side effects. And in one study, in a subgroup of patients with severe foot infections, ertapenem did not seem to do as well as piperacillin and tazobactam. The healing percentages were high, ranging from, say, 50 to 90%, including patients with osteomyelitis. I'd like to highlight a couple of those studies. One of them was an RCT of surgery versus antibiotic treatment that was in patients with limited forefoot osteomyelitis. It was a Spanish study. They randomized patients to either group. In that study, they did not find a significant difference among the two groups. Patients in the conservative treatment group got 90 days of antibiotic treatment. So that probably means that you can treat patients with limited forefoot osteomyelitis with conservative treatment or with surgical treatment. Another study looked at 6 weeks versus 12 weeks of antibiotic treatment, a French study where they did not find a significant difference among the two groups. Now, that group, patients that required immediate surgery, as in the previous study, were excluded from the study. Again, in such a subgroup of patients, it's safe to give 6 weeks of antibiotic treatment compared to 12 weeks of treatment. Perhaps it's possible to treat for even shorter duration of treatment. There's been a Swiss study that's been published after the guidelines were published. It looked at 3 weeks versus 6 weeks in patients with diabetic foot osteomyelitis where they debrided necrotic tissue. There was a non-inferiority RCT. In 93 patients, they had 0 to 2 interventions with a median number of surgical debridements of 1. And here you can see the results in the intention to treat analysis. Patients in the 3-week group were 84% of those were in remission after treatment, and in the 6-week group, 73% were in remission. There was a comparable amount of adverse events in both groups. So that means that if you include surgery in the treatment, you can probably get away with even 3 weeks. But some more studies are needed to the subject, of course. Now, how do we select antibiotics? Well, first of all, you have to target the proven or most likely pathogen and its susceptibility. And what is the most likely pathogen? Well, that depends on where you are in the world. For instance, if you would be in Colombia, there'd be differences between me living in the Netherlands. For instance, in Colombia, you're more likely to be murdered. Also, people in Colombia tend to make or even get more babies. But most importantly, the healthcare systems are completely different, and the circumstances are different. So people in Colombia spend a lot less money on healthcare. And the same is true within regions within the same continent. You look at the Netherlands, for instance, here that invisible dot on an invisible dot, you can see that the amount of Staph aureus resistant to methicillin, so MRSA, is low, especially compared to the southern European countries, so Portugal, Italy, Greece. And the same is true for carbapenem-resistant Klebsiella. A lot of resistance in southern Europe, and hardly any resistance in northern Europe. It wouldn't surprise you, you probably know that there's a direct correlation between the use of antibiotics and the amount of resistance. If you overlay the maps of resistance and antibiotics use in Europe, you see this. In southern Europe, they use a lot more antibiotics. And in northern Europe, there's a lot more resistance in southern Europe. So that means the more antibiotics we use, the more likely we are that we can't use antibiotics for very long. And what can we do as caregivers to prevent resistance? Well, don't prescribe antibiotics for non-bacterial infections. Also, we have to teach our patients not to ask for antibiotics. They're not the cure for everything. Sometimes it's better to perform surgery or to don't give antibiotics at all. So what's the most important pathogen? Well, those are probably the gram-positive cocci. For instance, Staph aureus, as you can see in this electron microscope image. And the idea then is this allegory where the diabetic foot infection is a snake. And the head of the cobra represents Staph aureus and beta-hemolytic streptococcus. And the tail represents gram-negative rods, anaerobes, and coagulase-negative staphylococci. If you then have a therapy directed at the head of the snake, you get rid of its fangs and poison, then you're left with an innocent tail. So the antibiotics should be aimed at Staph aureus and streptococci, but sometimes you need treatment for the tail as well. Usually not. Is that really true? Do you usually have monoculture results in diabetic foot infections? Not all the time. That paradigm is probably true in mild infection. We don't have any definite data. You might have a worse prognosis in case of polymicrobial flora. And you have to be cautious in severe infection and osteomyelitis. Why? Because in case of severe infection, the stakes are high, and if you then miss important pathogens, then the result will be an amputation. And also, you have to look at your local resistance profile. This is an example of a study that we've done in the Netherlands, where we looked at the coverage of the pathogens for clindamycin and ciprofloxacin combination. That used to be common in about 10 years ago in the whole of the Netherlands. We found that in several hospitals, That combination only covered 85% of the Staph aureus and 78% of gram-negative rods. It means that if you target Staph aureus as the most likely pathogen, we missed about 15% of the, in 50% of the cases, we missed the most important pathogens with our antibiotics. Okay, so what else do we do? How do we select an antibiotic? Well, we have to look at the clinical severity of infection. This is from the international guidelines. It's a pretty complex algorithm. If we then zoom in on it, you can see that there's a distinction made between subjects with a mild, moderate infection and those with a severe infection. And in case of a mild, moderate infection, you can probably get away with treating patients at home, outpatient. But if patients have a severe infection, you have to admit them, get them IV fluids, IV antibiotics, and probably surgery. Now, how do we define a severity of infection? Well, the International Working Group of Diabetic Foot and the IDSA have made a diabetic foot infection classification, where infection grade 1 is no infection. Infection grade 2 is 2 or more signs or symptoms of inflammation, swelling, erythema, pain, warmth, pus, and no other explanation than infection, so no gout, for instance. And if you then have an infection grade 3, you have more erythema, more than 2 centimeters, plus one of the other signs of inflammation, or you have a deep infection, an abscess, osteomyelitis, septic arthritis, or necrotic fasciitis. And the latest update of the guidelines, we made a distinction between those patients with and without osteomyelitis, because we believe that it leads to a different outcome and to different management. This is an infection of a person with a grade 3 infection to osteomyelitis. Now, infection grade 4 would be a person with sepsis, and then sepsis was then defined as a foot infection with systemic inflammatory response syndrome. So the classic definition of sepsis, not using the Q-sulfa score or MUSE or NEWS or any of the other new sepsis scores. And SIDS was then defined as 2 or more of the following: a fever or under temperature, tachycardia, tachypnea, leukocytosis or leukopenia. And again, we made a distinction between those with osteomyelitis and those without. Why do we do that? Why? Well, because it predicts which patients will be hospitalized, which patients will ultimately receive an amputation. But also, we can use it to guide our empiric antibiotic therapy. In case of mild infection, no recent antibiotic treatment. And if you live in a temperate climate, which unfortunately is not the case in Central and South America, you can get away with just targeting Staph aureus and streptococci. Remember the allegory of the snake. But in case of moderate to severe infection, if you live in a tropical or subtropical climate, or if there's ischemia, you might need to treat gram-negative pathogens as well, especially if you have a moderate or severe infection. There have been several papers from Pakistan, from Tanzania, from Turkey, pretty good papers that show that there's a lot more Pseudomonas and a lot more gram-negative rods in tropical and subtropical climates. Now, once you get the results back from your culture, you have to reconsider and specifically aim for the pathogen that you culture, and don't continue broad-spectrum antibiotics. Again, Pseudomonas, it's unlikely that it needs empiric coverage in the Netherlands, but you would probably need it if you would have a hospital in tropical Colombia. Now, in case of severe infection, you usually treat parenterally first and then switch to oral. In case of mild infections, you can usually get away with oral antibiotics. And then, fortunately, we could not find any evidence for the administration of topical antibiotics. Should we always give intravenously in case of osteomyelitis? Probably not. These are the results of the OVIVA trial published in 2019 in the New England Journal of Medicine, where they found that oral versus IV in a large group of patients that included a subgroup of patients with diabetic foot osteomyelitis, but also included prosthetic joint associated infections and spondylodiscitis. In that whole group, there was no difference in outcome if you treated patients orally or intravenously, but there were less side effects and less adverse effects in patients treated orally. Now, of course, you also have to consider the evidence for the efficacy of the agents for diabetic foot infections. But as I said earlier, only ticacycline is not a preferred option. Most of the other antibiotics have been studied. And what you always have to consider, but we don't know the full ramifications of this thing yet. A biofilm. Here you can see an electron microscope, a picture of a biofilm. And what's the case with biofilm? Well, bacteria in biofilm are less susceptible to antibiotics and they're less susceptible to antiseptics. On the left here, you can see the killing efficacy of tobramycin in Pseudomonas biofilm. Biofilm, it did a bit better than no tobramycin at all. But if you give it to planktonic bacteria, so those not in biofilm, as we culture them in the lab, then tobramycin was really effective. And the same is true here on the right for bleach and bacteria in biofilm. This is a very graphic image where you can see a droplet of Pseudomonas on a flat surface. A tablet of an antibiotic is put in the droplet, and then pictures are taken a while afterwards. As you can see, tobramycin, colistin, and ciprofloxacin are really effective in killing all the fresh Pseudomonas bacteria. But the longer the droplet stays on the table, the more biofilm is formed. And as you can see on the bottom, the antibiotics are not effective at all against the same Pseudomonas. But once again, we don't know the full ramifications of this phenomenon. Now, we also have to consider the risk of adverse events, including damage to the common cell flora. And the most important damage to the common cell flora is probably Candida stomatitis or vulvitis or Clostridium difficile diarrhea. But you also have to consider other toxic side effects, for instance, skin problems, liver problems. A fairly high percentage gets acute kidney injury, and anaphylaxis is a lot more uncommon. If you give IV therapy with central venous line, then you have to be aware that some of the lines will get infected. A vast set percentage, say about 1 promille per capita day, and there'll be some thrombosis. So the more you use central venous lines, the more likely it is that you get either infection or thrombosis. But as I said earlier, looking at the Oviva trial, you don't always need IV antibiotics. You can probably get away with oral antibiotics with good bioavailability most of the time. You have to consider the likelihood of drug-drug interactions. For instance, if you use rifampicin, drug availability. Not all drugs are available in all countries. Financial cost, of course, if you can choose between two strategies, you have to choose that are equal in outcomes or likely to be equal in outcomes. And you have to choose the cheapest one. So I know that you probably hear now, so I hear you saying now that, okay, you've told me all these things, now which antibiotics should I use? Unfortunately, there's no silver bullet. There are a lot of antibiotics that you can use. You can pick any one of these. In the Netherlands, we usually use a lot of flucloxacillin because we don't have a lot of MRSA, but we do have, say, 15% of resistance to clindamycin. But in case of proven susceptibility to clindamycin, we usually switch to clindamycin because it has good bioavailability. You can use cephalexin in case of clindamycin resistance, which has about the same coverage as flucloxacillin, but it's a cephalosporin with a bit better bioavailability than flucloxacillin, but it's an option. You can use amoxicillin clavulanic acid. You can also use that for severe infection. Piperacillin tazobactam in case of Pseudomonas, if you want to have coverage for Pseudomonas. Moxifloxacin in case of proven susceptibility, and ciprofloxacin, clindamycin combination with proven susceptibility. You can use a carbapenem if you have a lot of ESBL, linezolid, daptomycin, vancomycin for MRSA, and as said earlier, piperacillin and tazobactam for Pseudomonas. There is proof that treating clinically uninfected wounds does not improve outcome. That's been proven for diabetic foot ulcers, but also for venous leg ulcers. But I do know that a lot of doctors still prescribe antibiotics for non-infected ulcers. So that means that ulcers that are not red, painful, swollen, etc. I think we have to tell our new residents over and over again that it doesn't help to speed up wound healing. It's meant to kill bacteria, not to heal wounds. Okay, so coming to the end of my talk, infection is a clinical diagnosis. If you want to prescribe adequate empiric antibiotic treatment for diabetic foot infections, you have to know your local resistance profile. In case of mild infection, treat Staph aureus and streptococci. In the case of moderate to severe infection, you also want to include gram-negative organisms. And let's say, added to that, in case you live in a tropical climate, you have to consider treating gram-negative organisms also if you have a moderate infection. With that, I'd like to invite you to The Hague, where the 9th International Symposium on the Diabetic Foot will be held on the 10th to the 13th of May. And thank you very much for your attention.